Thank you, sir. With your permission, I am going to present my today's topic. It is obesity and cardiovascular diseases. So, most welcome everyone and good morning. I am Dr. Pradip Kumar, going to present the topics of selected for today's discussion. All of us know that obesity is the leading cause of preventable death next to smoking. It is the recent data, and today we'll discuss on the historic burden of obesity, global scenario, definition of obesity and cause, how to measure the obesity, adipose tissue, few words on genetics of obesity and pathogenesis of cardiovascular disease due to obesity and their treatment. Obesity is an historical burden for a long time for the mankind, and it is well known from the time of Hippocrates, when obese person was thought as a cursed people, and Hippocrates said that they should eat only once and take no bath and sleep and walked naked as long as possible. After that, a long time after, Daniel Lambert, it is a figure of Daniel Lambert, and said that British physician Thomas Short has said that no age has been more instances of corpulency than our own. With the translation, it means that at that time, corpulency, that is obesity, was the most instance of that time than any other time of the past. But interestingly, obesity is called the poverty of the first world. It is not the poverty in most of the world. Rather, it is a poverty of the first world like America. And the top 10 fattest countries in the world are USA, China, India, Russia, Brazil, Mexico, Egypt, Germany, Pakistan, Indonesia. So from this list, we can see that there is a mixed economical background. Not only the first world, the third world is also quite frequently seen in among the top lists. So what's going on in poor world? Why they are obese today? In a study of middle class of Africa, we can see that in Ethiopia, from 1984 to 2014, the obesity rate in women was just tripled in this period of time. And the food habit change in the Asia Pacific islands now have the highest rate of obesity in the world. Among them, Nauru is the number one, Cook Island is number two, and Marshall Island is number three. They are once well known for their dietary habit. They used to eat fish, coconut. Now they are switched their food to processed meat and fast foods, and all that happens is a dramatic change in their lifestyle, and obesity is increased. What about Middle East? Middle East also suffering from obesity. So 35% of Saudi Arabia people and 35% of Qatar, 38% of Kuwait, all are suffering from morbid obesity. So it is not the scenario told us that it is not the problem of first world. It is also a problem of the third world, also due to their shift of natural cultural habit and dietary habit to the modern fast food culture. So what is obesity? Obesity is defined as an increase in body weight because of excess of fat by WHO. So it can be defined as carrying excess weight, then weight is considered healthy in our normal terminology. That is body mass index more than 30 or equal to 30. And limitation of this estimation is it estimates overall body fat. So it is overestimate in a muscular person and underestimate in a person who lost muscle mass suddenly. So what is the how we calculate the BMI and obesity? BMI is calculated very simply by body weight, that is mass in kg, divided by height in meter square. And with this formula, we can translate it into, convert it into a pound also, and the formula is remains the similar result. So BMI gives us the obesity, diagnosis of obesity very simplified, in a simplified way, that is less than 18.5 is underweight, 18.8 to 24.9 is considered as normal weight, 25 to 29.9 is overweight, 30 to 40 this group are obese, and more than 40 are very obese. This is a simple classification, and it is a bit elaborated in this classification, that is in the obesity group, 30 to 34.9 are considered as obesity class 1, 35 to 39.9 is obesity class 2, and 40 to 49.9 are considered as obesity class 3. And there are also class 4 and class 5, that are class 4 are BMI more than or equal to 50 kg per meter square. They are considered as super obese, and BMI more than 60 or equal to 60 kg per meter square are considered as super obese. BMI is still the most used anthropometric index in the literature and persists as a strong predictor of cardiovascular disease mortality. Another terminology to measure the obesity is the waist circumference, and it is relevant to cardiovascular diseases. The goal value of waist circumference is in men less than 94 and women less than 80. So in that group, no risk of illness and due to overweight, and the slight health risk are bears the men in 94 to 101 inch and women 80 to 87 inch. Avoid this group are suggested to avoid weight gain or drop your weight, and significant health risk produced by more than 1 to 102 in women, and women in men and women more than 88. This group is with high risk, and they should drop their weight, seek for help for reducing weight from healthcare professionals. These are measured in centimeters. And another ratio is how we should calculate the waist hip ratio. And this is the another measurement, waist hip ratio. We measure our waist just under the lowest rib and hips at the widest portion of our buttock, then divide the parameters. For women, the ratio should be less than 0.85. For men, the ratio should be less than 1. And this is a this diagram is made considering the 3 criteria, and mainly the 2 criteria actually, the BMI and waist circumference, and the overweight group of BMI, that is 25 to 29.9, are in waist. In case of waist circumference, they are considered as increase if in men less than 40 inch and less than 35 in women, but they are of high risk and high considered as high waist circumference more than if in men more than 40 inch in men and more than 35 inch in women. So they are also classified as high, very high, and extremely high in correlation to the BMI and obesity group. So some words about body fat, the types and their distribution. All of us know that there are 2 types of adipose tissue. There is white adipose tissue and brown adipose tissue. White adipose tissue stores energy as large fat droplets. They are most commonly distributed in our body and helps with heat insulation, mechanical cushion, and as a source of energy. Brown fat stores energy as much smaller droplet size are small and burns them quickly, packed with mitochondria. Infants are born with rich stores of brown fat cell. So these are the, in short, types and functions of adipose tissues, and they are also have got some autocrine and paracrine autocrine and paracrine functions. This is a picture showing our from neonate to adult and the change of types of adipose tissue. Then in neonate, there are thermogenic brown adipose tissue are plenty, and when the child is in growing age, the white adipose tissue are increasing, and in adult, it is almost white adipose tissue and no almost a few uh, brown fat tissue. So this is also some talks about three types of adipose tissue, that is white adipose tissue, perivascular adipose tissue, and this is brown adipose tissue. So lipid content is very high in white adipose tissue, in also in the perivascular white tissue, and though it is called it is high in brown adipose tissue, but lipid droplets are smaller and contents is much lower in comparison to the other two groups. And mitochondrial concentration, that is very mitochondria means very active, energetically active and burning the fuels. So there is uh, uh, plenty in brown adipose tissue. That is the childs are active and they are actually feel warmer than the adults. We think that the children's neonates are very prone to cold, but this slide shows this, and physiologically they are with their plenty brown fat cells, they actually can generate their thermogenesis very quickly. Functions: storage of lipid and endocrine functions, possesses white adipose tissue and perivascular tissue. Also, in addition to thermogenesis, regulate the vascular tone, and the brown adipose tissue solely function as thermogenesis. So location: white adipose tissue mainly located in the subcutaneous tissue and pathologically in perivascular region, perivascular regions and also perivisceral regions, and interabdominal region is also their natural habitat. So brown adipose tissue, I already told it. So what happens? The risk of heart disease is higher because abdominal fat increases the production of LDL, that is bad cholesterol, the type of blood fat that can be deposited on the inside of the blood vessel walls and causes the atherosclerosis. This is our journey from early life to the modern life, and we are taking the fast food very frequently and generating our body a obese and abnormal pattern and ready for developing cardiovascular diseases. So according to distribution, they can be classified as subcutaneous fat, that is just under the skin, abdominal muscle, just under the abdominal muscle layer, this is intra-abdominal, and intra-abdominal fat. The problem is intra-abdominal fat, not the subcutaneous fat. I will discuss it later. So visceral fat, sometimes referred to as deep fat, grows around the inner abdominal organs like the stomach and liver, and the subcutaneous fat is located right under the skin, and subcutaneous fat is not as responsive to a good diet and exercise. Subcutaneous fat, we cannot burn it actually, and it is necessary for our integrity of the skin and underlying structures containing blood vessels and neurological structures, and they are not pathogenic. We actually concern about the visceral fats, that gains our weight when we absorb our change our dietary pattern and absorbs more than we need actually for our body. So visceral fats are higher cardiometabolic risk fat, and subcutaneous fat are considered as lower cardiometabolic risk. And this is the pattern of body fat distribution. This is in female it is pear shaped, and in men it is apple shaped. There is abdominal fat, and in female it is fat region is butter. So causes of obesity are physical inactivity, overeating or change of dietary habit, genetic background, diet high in carbohydrate, some medications, psychological diseases, and some systemic diseases like hypothyroidism, insulin resistance, polycystic ovary syndrome, and Cushing syndrome. In nutshell, pathophysiology is considered as three-layered dysregulation. There are defects in hypothalamic regulation of appetite by some hormones, and dysfunctional adipose tissue and cardiovascular disease, processes, and our lifestyle and cardiometabolic risks. So, hormonal regulation or obesity, the hormone leptin and insulin, sex hormones and growth hormones influence our appetite, metabolism, and body fat distribution. People who are obese have levels of these hormones that encourage abnormal metabolism and accumulation of body fat. In general, these hormones are obesity hormones. And there are some balance and counterbalance that is maintained in our body to maintain the optimum energy balance. That is three important. Actually, the two important, that is from adipose tissue, that is leptin, and from pancreas, insulin, and from stomach, the ghrelin. These three hormones are among them, leptin and ghrelin are more important in case of obesity. Ghrelin is a hormone produced by enteroendocrine cells of the gastrointestinal tract, especially the stomach, and is often called the hunger hormone because it increases food intake. Blood levels of ghrelin are highest before meal when we feel hungry, returning to lower levels after mealtime. Ghrelin may help prepare for food intake by increasing gastric motility and gastric acid secretion. Ghrelin activates cells in the anterior pituitary gland and hypothalamic arcuate nucleus, including neuropeptide Y neurons that initiate appetite. Ghrelin stimulates brain structure, having a specific receptor, the growth hormone secretagogue receptor A1A, GHSR1A. Ghrelin also participates in regulation of reward cognition, learning, memory, and sleep-wake cycle, taste, sensation, reward behavior, and glucose metabolism. In summary, we can say that ghrelin is the hunger hormone, which makes us hungry, and when its concentration increases and we cannot control our hunger, the ongoing cycle of feeling hungry after a few times causes us more intake of food, and it results in gaining weight. So there is a balance between ghrelin and leptin. Leptin, in other words, causes the opposite work, and leptin is the satiety hormone. It tells our brain that my satiety is full and you stop eating. So there is a balance between ghrelin and leptin. Leptin in case of taking food and feeling early satiety fully. So ghrelin is the appetite stimulator and leptin is the appetite suppressor. Normal leptin causes the normal appetite, increased metabolism, and normal weight. And they are also necessary for reproductive hormones, normal level of reproductive hormone. When leptin levels are low, brain does not suppress the hunger center, and the satiety center is not satisfied. So body always stay in a starvation mode, increase the appetite and decrease the metabolism. Reproductive hormones also decrease. Period may be problematic, problems with infertility. And like insulin resistance, leptin resistance also occurs. And in that case, leptin is quite normal, and appetite is, despite the normal leptin level, increase appetite and decrease metabolism, so weight gain occurs. In this picture, you can see that when the leptin is released from our adipocytes. So when adipocytes mass in obese people are increased, so we can say that their leptin levels are high. But why they do not control their appetite, control their taking food, despite their high leptin levels? This is this answer is explained by leptin resistance. So in this obese person, High leptin with leptin resistance causes their obesity gain ongoing. And stress due to release of some stress hormone, and this stress hormone cortisol catalyzes the carbohydrate and fat metabolism during stressful events. We feel uh, more urgent need of blood sugar levels for fast fuel supply, and this causes the high sugar level, consequently stimulate the release of insulin, which can lead to appetite increase. And insulin causes storage of uptake of glucose, and this extra uptake of glucose causes conversion of glucose to fat in adipose tissue, and obesity is increased. The disease spectrum caused by the obesity are quite a few exhausting list. First of all, the coronary heart disease with high blood pressure, high cholesterol and stroke, fatty liver disease, diabetes, breast, colon and endometrial cancers, osteoarthritis, sleep apnea and asthma. How obesity is related to cardiovascular risk? Visceral obesity is the culprit, I said before. It causes sodium retention and volume expansion, ultimately increase the cardiac output. It also increases the heart rate and increase the cardiac output. It causes endothelial dysfunction by perivascular adipose tissue, which causes atherosclerosis and increase arterial resistance. It causes diabetes mellitus and dyslipidemia. They are also responsible for atherosclerosis. All of them are responsible for hypertension, causing eccentric hypertrophy, and ultimately eccentric as well as concentric hypertrophy, and ultimately they can cause failure of heart function and coronary artery disease and sudden cardiac death. The cardiac complications of obesity are very uh, eventful and strongly related to the mortality. Here is the mechanism linking to obesity and cardiovascular disease. In obesity, mechanical effect, there are three types of effects actually. The mechanical effects of increased weight gain on chest wall, also the epicardial and visceral fat causes this. This causes obstructive sleep apnea, increased cardiac workload, restrictive cardiac filling pattern, left heart hypertrophy, obesity, obesity-induced cardiomyopathy, adipositas cordis, it is called adipositas cordis, and obstructive sleep apnea causes atrial fibrillation, all predisposed to heart failure. And obesity also is a pro-inflammatory and pro-thrombotic state due to their secretion of adiponectin that are paracrine and endocrine action. They causes directly acute coronary syndromes, and they're associated with atherosclerotic function are associated with components of the metabolic syndrome. So increased insulin resistance occurs, ultimately causes hypertension, dyslipidemia, and diabetes mellitus. All are the predisposing factors and aggravating factors of acute coronary syndromes and ultimately heart failure. This is the scenario of our uh, obesity, how obesity causes cardiovascular disease and mortality. And then management plan. There are three management plans at present depending on the BMI. Healthy eating and physical activity and behavioral therapy are the baseline of this therapy strategy. If they fail, the pharmacological management starts. If they fail, the surgery starts. And when BMI is more than or equal to 25 with some complications, only eating and dietary approach is enough. When BMI is more than 27 or equal to 27 with complication, all the dietary, physical activity and behavioral therapy, we can prescribe some pharmacological medication. And in case of BMI more than 30, that is obese group, we can start with our dietary advice, physical activity and behavioral therapy. Pharmacological management is inevitable, and more than 35 is the indication of surgery. Below 35, surgery is not indicated. So there are three main option of treatment of obesity, that is diet, therapy and exercise, and behavioral treatment, and pharmacological agents, that is sibutramine, orlistat, bupropion, and surgical therapy. There are a lot of surgical options. Three are mentioned here: gastric bending, gastric bypass, and biliopancreatic diversion. So, what food is the ideal food we should tell? All of us know, but none of us are not really practice it quite frequently. All of said about lot of vegetable and sea fish like salmon, lot of fruits and chili peppers. That is a vegetable item available in our country. Blueberries, all kind of berries, and chia seeds. This is a recently uh, very well spoken all over the net. The chia seeds, that is a Mexican and seed nowadays, and it is available from Mayan uh, culture. These are chia means energy. So chia seeds are full of energy. Who the people wants to lose their energy and eat more calorie in short volume of food. Chia seeds are very good source and they are rich in high antioxidants. They are very needful there in our body. So three types of foods are suggested. Group one, we should try to eat lot. That is fruits and vegetables and breads. Probably these are whole grain breads and grains such as rice and pasta and moderately taken foods are dairy products such as milk, cheese, and yogurts, lean meats, that is meat without fat, chicken without skin, fish, and nut. And these foods are said that to take very infrequently, and it is called eat these foods sometimes. That is sweet biscuits, two smalls, not regularly, chocolate coated bars, not regularly one, but potato chips. If you have to have only 30 grams and not regularly. Ice cream very infrequently. Lollies and chocolates very infrequently. Cake and muffins infrequently. So overall dietary recommendation are plant-based and Mediterranean diets are encouraged. Diets should be enriched in vegetables, fruits, legumes, nuts, whole grains, and fish. Mono and polyunsaturated fats should replace saturated fat. Sodium and cholesterol intake should be optimized. Consumption of processed meat, refined carbohydrate, and sweetened beverage should be minimized. Why sweetened beverages should be minimized? Because all of us know that source of glucose is not the source of carbohydrate is not glucose in these cases. Many fructoses and unnatural sweeteners are involved in these types of food, and our body, not only our body, the all species animals are can take this and process this sugar, that is glucose. 80% glucose can be utilized in our body, but in case of fructose, it is directly metabolized by liver, not in the other peripheral tissue. So any fructose taken overtaken, it is stored in our body and it is converted into the fat. So fructose intake other than natural fruit containing fructose are not encouraged, and we are suggested that when we take the beverage or any kind of processed food, we should always look for the level of fructose and glucose separately before taking and having these foods. So second option is exercise. We can be fat, but we fit also, because not always the fats are pathological. If the fats can be maintained with fitness and dietary habits, that can be uh, of no harm. In this context, we will focus on fat but fit preparation. In spite of being obese, we have a relatively good cardiorespiratory fitness level, and it can be maintained by exercise and dietary habit. In case of sporting disciplines, there are high intensity, medium intensity, and low intensity exercises. This is shown here. Skills, uh, first golf, table tennis, shooting, curling, br- brawling, these are of low intensity exercise, and sailing, yachting, these are medium intensity. These are not actually readily available in our country. So in exchange of the that we can go to the mixed pattern of sports, that is soccer, basketball, and handball are considered as low intensity, whereas volleyball and tennis are considered as medium intensity. Uh, Hockey, rugby, fencing, tennis, water polo, soccer, competitive soccer, basketball competitive, and handball competitive are considered as high intensity. In endurance sports, jogging, long distance walking, swimming, recreational swimming are considered as low intensity, and speed walking, that is high speed jogging, mild and long distance running, style dancing, these are considered as medium intensity sporting activity, and cycling, this is very possible for us, are high intensity endurance exercise. The general recommendation for exercise and sports in healthy individuals, not for the obese, for every person. It is recommended that at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity aerobic exercise or an equivalent combination thereof is recommended in an healthy, all healthy adults are class 1 with level A evidence. A gradual increase in aerobic exercise to 300 minutes per week of moderate intensity or 150 minutes per week of vigorous intensity aerobic exercise or an equivalent combination is recommended for additional benefits in healthy adults are also class 1 with level A evidence. Regular assessment and counseling to promote adherence and, if necessary, to support an increase in exercise volume over time are recommended as class 1 reference level B. Multiple sessions of exercise spread throughout the week, for example, on 4 to 5 days a week, and preferably every day of the week are recommended, that is 1B. Among individuals with low to moderate cardiovascular disease, the participation in all recreational sports should be considered without further cardiovascular evaluation, that is class 2A, level of evidence C, cardiac screening with family history, symptom, physical examination, and 12 lead resting ECG should be considered for competitive athletes in risk group, that is class 2A, level of evidence C. Clinical evaluation, including maximal exercise testing, should be considered for prognostic purposes in sedentary people and individuals with high or over very high cardiovascular risk who intend to engage in intensive exercise programs or competitive sports are considered as class 2A, level of evidence C. In selected individuals without known cardiovascular non-CAD or have a very high cardiovascular disease risk, for example, score more than 10%, strong family history or familial hypercholesterolemia, and want to engage in high or very high intensity exercise, risk assessment with functional imaging test, coronary CCTA, or carotid or femoral artery ultrasound imaging may be considered. This is class 2B, level of evidence B. But in our present topic, special considerations for individuals with obesity, hypertension, and dyslipidemia or diabetes are recommended as in obese individual, that is BMI more than or equal to 30 kilogram per meter square or waist circumference more than 80 centimeter for females or 94 centimeter for males, resistance training more than or equal to 3 times per week. In addition to moderate or vigorous aerobic exercise, at least 30 minutes 5 to 7 days per week is recommended to reduce cardiovascular disease, class 1 level of evidence A. In individual with well-controlled hypertension, resistance training more than or equal to 3 times per week, in addition to moderate or vigorous aerobic exercise, at least 30 minutes, 5 to 7 days per week is recommended to reduce blood pressure and cardiovascular diseases. This is also class 1 level of evidence A. Among individuals with diabetes mellitus, resistance training more than or equal to 3 times per week, in addition to moderate or vigorous aerobic exercise, at least 30 minutes, 5 to 7 days per week is recommended to improve insulin sensitivity and achieve a better cardiovascular risk profile. Among adults with well-controlled hypertension but high risk and target organ damage, high-intensity exercise is not recommended and it is class 3. In individuals with uncontrolled hypertension, high-intensity exercise is not recommended until blood pressure has been controlled. It is also class 3. Few talks about behavioral modification. There is self-monitoring of weight, calorie intake, exercise intensity and frequency. A goal should be set for achieving the optimum level of weight. Stress reduction with pharmacological therapy or psychotherapy. Stimulus control, psychological evaluation when indicated, mobilization of social support and resources, use of commercial weight loss support programs available not in our country, it is available in Western country like Weight Watchers and Noom. When diet and lifestyle modification fails, we should consider the pharmacological therapy to be used in conjunction with appropriate diet and exercise and behavioral counseling. The indications is BMI more than 30, BMI 27 to 29.9, that is overweight group, with comorbidities and failed attempts at lifestyle modification in 6 months are considered for pharmacological therapy. But if they have no comorbidities or complication, they should be on diet, exercise, and behavioral counseling. Goal of our weight loss should be 5% at 3 months. It requires close follow-up monitoring for response, progress, and side effects of the pharmacological treatment, ideally with multidisciplinary team physician, registered nurse, nutritionist, and behavioral therapist, exercise physiologist. FDA approves many drugs, among them Orlistat is a common drug which acts in inhibiting pancreatic lipase, and its dose is 120 milligram TID. Side effects are not so serious. Those are gas and flatulence. Phentermine, that is acts by this is amphetamine derivative, and dose is 15 to 37.5 milligram daily. It causes anxiety, irritability, and dry mouth. Lorcaserin, that is serotonin 2C receptor agonist, 10 milligram BID dose. This causes some neurological problem, dizziness, dry mouth, and constipation also. Liraglutide, this is Saxenda. This is GLP-1 agonist, 0.6 milligram subcutaneously used to 3 milligram weekly. This causes nausea, emesis, diarrhea, and may cause serious pancreatitis. And a drug Plenitry, that is a hydrogel particulate, 3 capsules with meals should be taken, and the stomach will full with this Plenity, and no food. The message will be sent to that our appetite is full, satiety center will be activated, and the side effects are bloated feelings, distension, and diarrhea. Orlistat is approved by FDA in America in 1999, and mechanism is inhibit fat absorption. Adverse effects are mostly gastrointestinal. Overall, mild weight loss. It is considered as mild weight loss agents with a relatively less side effect profile. Naltrexone or bupropion, it is approved in 2014, and it acts with synergistic effect at hypothalamus via POMC neurons. Its adverse effects are nausea, dry mouth, and constipation, and contraindications are uncontrolled hypertension. So we cannot prescribe bupropion. Seizure disorders, opioid use, concurrent opioid use, and recent use of MAO inhibitor may be helpful with binge eating, disordered eating, and concurrent mood disorder. The psychological cause of high intake of food can be treated with bupropion with in mind that the side effect profile should be monitored. There is another option, leptin replacement therapy. This figure shows before leptin a 3 years boy and after leptin at the age of 6 years. It's a dramatic change, and it is a very good drug for genetic causes causing leptin deficiency. From some surgical options are available. That is intragastric ballooning. The procedure is figured here. It is a Orbera procedure, inserted under light sedation and OPD maneuver. Endoscopically, 6 months is for 6 months it is uh, resided in the stomach, and after 6 months it is removed. Within this 6 month time, the patient will intake less food and obesity will be reduced. Same intragastric ballooning, another process is sparse adjustable ballooning system. I'm not going to details. And truly surgical procedure, one of them is sleep gastrectomy. Excision of 80% of the stomach is done. The antrum is preserved to maintain gastric emptying. Gastric imbrication is a non-resectional variant of this sleep. This is another procedure. So 80% of the stomach, except the gastric antrum, is resected. And this is another process not involving the resection of stomach. It is Roland-Y gastric bypass. Goal to restrict the gastric reservoir. So it advances its control food intake. Dumping reduces intake of sweets. Reversible if indicated. It can be reversed. So it is considered as a alternative procedure. And some space occupying devices are endoscopic devices are available. A reshaped integrated dual balloon system, Orbera, I discussed. Ovalian balloon system, sparse, I discussed. Ellipse balloon and transpyloric shuttle. So these are all space occupying devices. And the last, the cosmetic one, the bariatric surgery. Bariatric surgery is a surgical option for losing weight in people who are extremely overweight and their weight poses a health hazard. The procedure involves the surgical removal of a part of a stomach to reduce its capacity or to restrict the absorption of food from the intestine. There is an option that is there is a combination of these two methods is also available. So aim of the bariatric surgery is to reduce the capacity of the stomach, restrict how much food the stomach can hold at any time, and so promote early satiety, to prevent food from getting absorbed so that fewer calories are released into the body. So these are the all methods of treatment at present available, and that's from me. That's all from me today. Thank you all for your patient hearing, and I am opening the question session, and my beloved sir will uh, help me in this session, I hope.
Thank you, sir, for nice presentation, sir.
Come on, কোনো question?
স্যার ওই যে 5% বলছিলেন 3 মাসের মধ্যে 5% বেশি কমানো যাবে না স্যার। আর আগে যে আমরা
জি জি
জি
প্রশ্ন
আগে
করুন।
স্যার আগে যে আমরা বলতাম যে এই 1 মাসে 2 কেজির বেশি মানে আর সপ্তাহে আধা কেজির বেশি, স্যার ওইটা কি ঠিক থাকবে স্যার?
এইটা হচ্ছে একদম লেটেস্ট, সম্ভবত এটা 18-19 সালেরই গোল সেট করে দেওয়া হয়েছে যে ইন্ডিভিজুয়ালাইজড গোল। দ্য গোল ইজ ইন্ডিভিজুয়ালাইজড পারসনস 5% ওয়েট, তার ওয়েটের 5% আমরা 3 মান্থসে টার্গেট করব, এইটাই সেট করা হবে। মানে কোনো ফিক্সড টার্গেট আর এখন করা হচ্ছে না যে 2 কেজি মান্থলি সবার জন্য। যেমন যে লিন কিন্তু ওবেস, তার ক্ষেত্রে কেজি হিসাবে ধরলে একটু প্রবলেম। তার ওয়েটের টোটাল ওয়েটের 5% ধরলে সেটা সব দিক দিয়ে ফিজিওলজিক্যালি বেনিফিশিয়াল। এই জন্যই সম্ভবত এটা করা হয়েছে।
থ্যাংক ইউ স্যার।
বদরুল সাপ্লিমেন্ট করেন আপনার টপিকস।
স্যার আপনি যেটা দেখাইছেন স্যার, যে বিএমআই যে রেজিস্টার দেখাইছেন, ডব্লিউএইচও ক্লাসিফিকেশন দেখাইছেন, ওই ওবেস, স্যার এটা আমাদের এশিয়ান তো স্যার চেঞ্জ আছে।
হ্যাঁ চেঞ্জ আছে, আমি একটা দেখাইলাম আর কি।
যে
আপনি
এশিয়ানের
বলেন।
ক্ষেত্রে, এশিয়ানের ক্ষেত্রে যেটা বলছে স্যার, যে 25 এর উপরে হইলে স্যার ওবেস, হ্যাঁ, আর 18.5 টু 22.9 এটা স্যার নরমাল, আর 23 থেকে 24.9 এটা ওভারওয়েট।
এশিয়ানদের এই যে এশিয়ান পপুলেশনে যারা ভাত খায় এদের আসলে হাই কার্বোহাইড্রেট ইনটেকটা খুব প্রবলেমেটিক। এই জন্য আমরা তো ডায়াবেটিক প্রিভ্যালেন্সও, ইনসুলিন রেজিস্ট্যান্সও বেশি। আবার ইনসুলিন নিজেই তো সেলের মধ্যে গ্লুকোজ ঢুকাই দিচ্ছে, এত গ্লুকোজ গিয়ে হবে কি? আমরা তো ধরেন এজ আ ডায়াবেটিক পেশেন্টের কথাই চিন্তা করি, ইনসুলিন যে দিচ্ছি আসলে কি করতেছি? ইনসুলিন দিচ্ছি তো গ্লুকোজটা তো বার্ন হচ্ছে, বার্ন তো হচ্ছে না, বার্ন তো একটা কথার কথা, এটা তো সেলে ঢুকতেছে। সেলে যে এত গ্লুকোজ আমরা ঢুকাই দিচ্ছি, মনে করেন একটা ওবেস পারসন, সেলে গ্লুকোজটা ঢুকাই দিলাম, এটা তো যাচ্ছে কোথায়? এটা তো আলটিমেটলি ট্রাইগ্লিসাইড হিসেবে থাকতেছে, তাই না? সেলের জিনিস সেলেই থাকতেছে, আলটিমেটলি ঘুরাই পেঁচায় কিন্তু আমরা দেখেন মানে লং টার্ম বেনিফিট বলতে গেলে কিন্তু খুব ঝামেলা। লং টার্মে কিন্তু আপনি আপনার তার ক্যালোরিটা কোথায় বার্ন করলেন, ক্যালোরি কিন্তু জায়গায় রয়ে গেল, আপনি ব্লাড গ্লুকোজটা এন্ড গ্লুকোজ রিলেটেড কমপ্লিকেশনটা রিডিউস করলেন, তাই না? তো এখানে বলা হচ্ছে যে ফার্মাকোলজিক্যাল থেরাপি যত ভালোই হোক, এটা যদি আপনি ডায়েটারি হ্যাবিট এবং এক্সারসাইজের সাথে মানে বার্নিং করার যে জায়গাটা আমাদের, একটা হলো লেস ইনটেক এন্ড বার্ন করবেন, এই তো কাঁচামালের কমাই দিলাম এবং পুরানো বাড়াই দিলাম, এই দুইটাতে এক্সারসাইজ এন্ড ডায়েট ছাড়া সম্ভব না। শুধু আমি শুধু ফার্মাকোলজিক্যাল ট্রিটমেন্টে যাব, এটা কোনো এইসব ডিজিজের লং টার্ম বেনিফিট আনে না, ওবেসিটির জন্য আনে না, ডায়াবেটিসের জন্য আনে না, এবং এগুলো তো সবাই মেটাবলিক সিন্ড্রোমের পার্ট, এদেরকে একসাথেই চিন্তা করতে পারবেন আপনি। আমরা তো ইনসুলিন দিয়ে দিলাম, ব্লাড গ্লুকোজ কমলো, আর গ্লুকোজটা গেল কই? গ্লুকোজ তো গেল সেলে, এডিপোস টিস্যুতে গেল, মাসলে ঢুকলো, তাই না? তো সেলের মধ্যে এই গ্লুকোজটা তো আপনার কনভার্ট হচ্ছে, শুধু ইউজড হচ্ছে না, কতখানি আর ইউজ হচ্ছে? ইউজের জন্য তো আপনার আছেই প্ল্যান্টি, সেটা তো ইউজ হচ্ছে, আপনি দিলেন। তো এইভাবে আমাদেরকে চিন্তাটা কিন্তু ওইভাবে করতে হচ্ছে। এবং এশিয়ান পিপলটা কিন্তু ওই যে ভাত খাওয়ার জন্য আমরা কিন্তু খুব প্রণ, এবং আমাদের জন্য এটা ঠিক আছে, এটা নিচে হওয়া উচিত ওবেসিটি। আজকের টপিকটা এমনিতে ছোট,
সুন্দর হয়েছে স্যার, আপনার ডায়াগ্রামিক সব সুন্দর স্যার, সুন্দর হয়েছে,
একটু কমপ্লিকেটেডও আছে আবার।
জি স্যার, না তারপরে স্যার অনেক, এটা অনেক কমপ্লিকেটেড স্যার, অনেক বই এত কি নাই স্যার।
না বইয়ের মধ্যে তো আসলে
হাসতে স্যার, হাসতে তো স্যার এত মানে কি দেওয়া নাই মোটামুটি।
এটা তো ওই যে আমরা একটু সময় পাইছি, তো সময় পাইলে কাজটা করা যায় সুন্দর করে, সময় না পাইলে তো এই প্রেজেন্টেশন গুলা এত সুন্দর করা যায় না। চেষ্টা করা যায়, আরো তো কত কথা আছে, সবই আলোচনা করা যায়। আপনি সাপ্লিমেন্ট করেন, আপনার তো ব্যাপক এই রিলেটেড করা লাগে, একটু সাপ্লিমেন্ট করেন আমরা শুনি, একটা তো পাইলাম। ওই যে দেখেন 3টা হরমোন, গ্রেলিন সম্পর্কে আমরা কিন্তু খুব বেশি জানিই না, তাই না? জানার কথাও না। গ্রেলিনটা এমনি গল্প করি, সময় না আছে যেহেতু। গ্রেলিন তো আমাদের স্টোমাক হাঙ্গার হরমোন হিসাবে সিক্রেট করেই যাচ্ছে, আমরা হাঙ্গরি ফুড দেখলেই হাঙ্গরি হয়ে যাচ্ছি, বা বেশি বেশি খাইতে যাচ্ছি। সেখানে আবার একটা জায়গা আছে ব্রেনে, হাইপোথ্যালামাসে, ওখানে নিউক্লিয়াস একুইভেন্স, সেও কিন্তু এই ইয়ে করতেছে, ফিজিওলজিক্যালি আমাদেরকে ফুড ইনটেকে প্রমোট করতেছে। আবার ওই যে লেপটিন, দেখেন এই ওবেসিটিটা অনেক ক্ষেত্রে ডায়াবেটিসের সাথে মিল আছে। কিন্তু কিভাবে? ডায়াবেটিসের টাইপ 2 ডায়াবেটিসে ইনসুলিন রেজিস্ট্যান্স যেমন 1 নম্বর, এখন ওয়েস্টার্ন ওয়ার্ল্ডে জেনেটিক বলেন আর এই বলেন, লেপটিন রেজিস্ট্যান্স কিন্তু মারাত্মক, এবং এই লেপটিনটা ইনজেক্টেবল পাওয়া যায়, সাবকিউটেনিয়াসলি দিলে, ওই যে দেখাইলাম তো একটা স্লাইড, ট্রিটমেন্টটাও কিন্তু লাইক ইনসুলিন, এটা দিলে ড্রামাটিক রেজাল্ট। সো ওবেসিটি আমাদের যদি আমরা ইভালুয়েট করতে পারি, তাহলে কিন্তু আমরা আলটিমেটলি ওবেসিটির যে কমপ্লিকেশন এবং কোমরবিডিটি গুলো ডেভেলপ করতেছে, পাশাপাশি হাইপার টেনশন, ডায়াবেটিস, এগুলো কিন্তু আমরা অনেক আগেই ট্রিটমেন্ট করতে পারি। কিন্তু আমরা আমাদের তো ওইভাবে আমরা অ্যাপ্রোচটা এখনো ডেভেলপ হয় নাই, বা মানুষ ওইভাবে অভ্যস্ত না। যদিও এখন অনেক বেশি নলেজেবল এবং অনেকেই জানেন, হাঁটাহাঁটির রেটও অনেক বেশি, সবাই হাঁটে, ডায়েটের ব্যাপারে খুব খুঁতখুঁতে। তারপরেও যে স্ট্রাকচার্ড ট্রিটমেন্ট ডেলিভারিটা এরকম যদি হইতো যে আমরা ওবেস গ্রুপটা টার্গেট করে যদি আগাইতাম, তাহলে হয়তো ডিজিজটা আর একটু প্রিভেন্টেবল হইতো। এই জন্যই বলা হচ্ছে ওবেসিটি ইটসেলফ ইজ এ ডিজিজ এবং এটা প্রিভেন্টেবল কজ অফ ডেথ আফটার স্মোকিং। এবং এর কারণটা থার্ড ওয়ার্ল্ডে ইথিওপিয়ার মতো দেশ যেখানে খাইতে পারে না, সেখানে দেখেন আপনি, আমি যে স্লাইডটা দেখাইছি, অবাক হয়ে যাওয়ার মতো। কোথায় দেখাইলাম? এই যে ইথিওপিয়ার মহিলারা 1984 সালে দেখেন, সেখান থেকে 1% যদি ধরেন, আজকে 2014 এর ডাটা বলতেছে 6% গেছে, 6 গুণ তাদের ওবেসিটি বাড়ছে। তাদের পোভার্টি জায়গাতে আছে, কিন্তু ওবেসিটি বাড়ছে ডিউ টু ফাস্ট ফুড ইনটেক এন্ড লাইফস্টাইল চেঞ্জ। একই কথা দেখেন, এই যে দেশগুলো, এগুলা ছিল টুরিস্টদের উপর নির্ভরশীল এবং এদের খুব সিম্পল লাইফস্টাইল ছিল। এরা ফিশ এবং কোকোনাট দুটো অ্যাভেলেবল জিনিস, এর উপরে এদের লাইফস্টাইল ছিল। এরা এটা থেকে চেঞ্জ হয়ে গেছে যখন ডলার আসা শুরু করলো, এরা ফাস্ট ফুডের দোকান গজাইলো, ফাস্ট ফুড সব খাওয়া শুরু করলেন, প্রসেসড মিট, ক্যান্ড মিট, নিজের মাছ থুয়ে ক্যান্ড মিট আমদানি করে খায়। এটা হলো সোশ্যাল একটা স্টিগমা, যে আমি খুব, যে আমাদের যেরকম এক সময় খুব ব্র্যান্ডেড গাড়ি, হ্যাঁ, ফাস্ট ফুড, এগুলো আমাদের মধ্যেও ছিল, তো এগুলা ওদেরকেও ধরছে ব্র্যান্ডিং এবং প্রচারের কারণে। তারা খুব কাঁচা ডলার দিয়ে এগুলো খাওয়া শুরু করলো। আলটিমেটলি ওয়ার্ল্ডের হাইয়েস্ট ওবেস গ্রুপ হইলো এখন তারা। ছোট্ট ছোট্ট দেশ, দ্বীপ দেশ, নাউরু, কুক আইল্যান্ড, মার্শাল আইল্যান্ড, সার্চ দিলেই পাবেন নাউরুতে 61% ওবেস এবং মরবিড ওবেসিটি। এটা হয়। মিডল ইস্টে টাকা আছে, ঠিক আছে, সময় নাই, ফাস্টফুড ওরাও ধরছে, ট্রেডিশনাল, ওদের তো সমুদ্র আছে, ফিশ ফুড থেকে এখন ফাস্টফুড ধরছে। সো একটা কথা বলা হয় যে ন্যাচারাল ফিস্ট না ফাস্ট ফুড। তো ফাস্ট ফুড ধরলে যা হবে, ওবেসিটি বাড়তেছে। আমাদের তো ভেজাল এবং মিলাইয়া সবকিছু, আমাদের এশিয়া তো পিকচারটা সেম। এবং ইন্ডিয়ান সাবকন্টিনেন্ট, ইন্ডিয়া, পাকিস্তান, বাংলাদেশ, কিন্তু ভালো নয় যে টপ 10 কান্ট্রির মধ্যে আমরা আছি, কিন্তু বাংলাদেশের নাম নেয় নাই। কিন্তু বাংলাদেশ নাই এই কথাটা কে বলবো? হয়তো ডাটা নেই, যেহেতু ইন্ডিয়া ঢুকছে 3 নম্বরে, পাকিস্তান আছে 9 নম্বরে, বাংলাদেশ কি 10, 11, 12-তে না থাকার তো কোনো কারণ দেখি না, তাই না? So half of all obese people in the world lives in these 10 countries, according to a study published in the Lancet. It's Lancet data. স্যার যদি একটু শেয়ার করতেন আমাদেরকে।
ওদের কি কোশ্চেন আছে কিনা আর কোনো?
না স্যার, কোশ্চেন তো আর পাচ্ছি না।
পরীক্ষা যেটা হইতেছে পরীক্ষার সময় ওবেসিটি এইগুলো ড্রাগ গুলো জিজ্ঞাসা করে, ম্যানেজমেন্টটা জিজ্ঞাসা করে।
পরীক্ষায় তো স্যার রিটেনে আসে এটা।
শর্ট নোটটা রিটেন। থাকে তাহলে ছেড়ে দাও। আর এটা একটু তোমার এই প্রেজেন্টেশনটা একটু দিয়ে দিও, সেগুলো দিয়ে দিও।
আচ্ছা স্যার,
আমরা ওখান থেকে নিয়ে নেব।
আচ্ছা স্যার,
ঠিক আছে। থ্যাংক ইউ।
আপনি স্যার শেষ করে দিচ্ছেন।
জি, না ঠিক আছে, ধন্যবাদ সকলকে।
থ্যাংক ইউ স্যার।